Good afternoon, everybody, and welcome to this session on STEMI, and the title is The Future of STEMI Care, a new treatment for bridging the gap from diagnosis to treatment. And we will speak a lot about pre-treatment of these patients with a thrombotic event. So we have two speakers along with me. I'm Gilles Montalesco from Paris, from this city. Welcome to Paris, which will be Olympic this summer, as you know. But this session is going to be Olympic also. We have two famous cardiologists with us. We have Arno Vanthoff to my right, and we have Gerd Tenberg on my left, and both will give a presentation. I'm going to start off with a short introduction. Of course, we will keep time to take your questions and have a real discussion on this topic. So this is a short presentation just to say what are the objectives of this session also. And let's start with a case. A very simple case. This man is 57 years old, and he has a cardiac arrest. And when the MICU, which is the ambulance with a doctor and a nurse on board, arrives, this is what they have on the first recording. Typical cardiac arrest, and they defibrillate the patient. CPR is started, and the first EKG recorded is this one, which, as you can see, is not of good quality, but we can understand why. But is clearly a STEMI, which is an extended inferior STEMI with ST elevation in 6 leads of this electrocardiogram. So the patient is started to be transferred to the cath lab, and the estimated transfer time which is given to us is 15 minutes. And the question is, what shall we give to this patient during transfer before undergoing a coronary angiogram and possibly a primary PCR? And this patient received aspirin, anticoagulation, and GPI, glycoprotein 2B3 inhibitor, and he was transferred to us. And this is what we got at the time of admission. And clearly he has a nasty right coronary artery, but as you can see, the culprit artery is a circumflux artery, which is suboccluded, maybe with some reopening of the artery by the GPI given during transfer. I will not go further with this case, but just to say that I still follow this patient at my consultation, because this case is dated 2008. So 15 years ago, we gave aspirin, anticoagulation, and a GPI, and I must tell you, I must confess, this patient would happen today. He would not receive a GPI in the ambulance. He would not receive probably aspirin and anticoagulation, and be sent to the cath lab for PCI. And clearly, 16 years later, we do not pre-treat the patient, and the fault is probably in the guidelines. So what are the lessons from the past? Just to remember that you have here the two chairmen of these two studies, old studies, on time 2, with Arno at the table, and Admiral, as that we conducted here in Paris and France. And both studies showed that in early presenters, when you give a GPI, tirofiban on the right, RioPro on the left, it works. It reduces clinical events, including in this patient that received 600 milligrams of clopidogrel at that time. And of course, the important point here is that these patients were early presenters and clearly had platelet-rich thrombus. But we have seen in the past negative studies, and these negative studies were performed usually in late presenters, BRAVE 3 or Cardiac. And Cardiac, you may remember, was a negative study, but with a nice trend for RioPro at the time in this study, in favor of RioPro. But you may also remember that cardiac, half of the patients were not stented, and that 12% of patients were not even STEMIs. So despite these limitations, we had a nice trend for ReoPro in these patients, but late presenters with fibrin-rich clots, and it works less well in this type of patients. If you look at the global picture, this is what we have, a list of green studies, which are the positive studies in high-risk patients presenting early with the STEMIs, and the red studies, which are the negative studies, low-risk patients or patients presenting late after the onset of MI, and sometimes both together, low risk and late presenters. But if you take, for example, FINESS, which is a negative study, and if you look at this subgroup of patients presenting early with a certain degree of risk, a TIMI score of more than 3, and they presented within 4 hours of symptom onset, you find again the benefit of GPIs in these patients with a nice and significant reduction of events with abciximab at the time in FINESS, which was globally negative because lots of patients presented late and clearly impacted the global result. Finally, we have meta-analysis because we had lots of studies with GPIs, and as you can see here, one of these meta-analyses showed a reduction of mortality at 30 days with GPIs. And this is where we stand with this data, but also with the present guidelines, the present recommendations from ESC. And if you look at the evolution of these recommendations, you have all sorts of colors, all sorts of recommendations. It goes from 2A, 2B, to class 3, and sometimes C level of evidence, A level of evidence, very difficult to understand. And the last set of recommendations globalize all types of ACS together, as you may remember, non-ST elevation ACS and ST elevation myocardial infarction. And we got this class 3 recommendation for GPIs as a pretreatment in patients with an ACS, including STEMIs. And this is where we have a problem, because the only reference that we have for this recommendation is early ACS, which is a study performed in non-ST elevation myocardial infarction. And if you look at the global picture, with these recommendations for STEMIs, non-ST elevation ACS, nowhere there is a recommendation for an IV antiplatelet agent. Nowhere there is a recommendation for a strong antiplatelet therapy in these patients, including in STEMIs. So clearly they are undertreated when they come to the cath lab, and it's not prasugrel or ticagrelor that are going to work during your PCI. So you're left with almost nothing, possibly aspirin if you use IV aspirin with a rapid effect. And it's not better for P2Y12 inhibition. As you know, we have 2B recommendations for all the situations, including for cangrelor, which is an IV drug, which is tolerated in naive patients and STEMI patients. Most of the time they are naive, but you have only a 2B recommendation for cangrelor, and this is, of course, a limitation of the drug. We do not have a single randomized study in STEMI patients with cangrelor. We have only subgroup analyses. So this is where we stand. The objectives for the future and for this session outlined on this slide. What is the ideal drug for an acute STEMI with an indication for primary PCI? We would like to have a drug with a fast onset of action, of course. We would like a drug which is easy to administer, maybe easier than what we had in the past, which was an IV administration with an infusion after the bolus. We want something with a potent antiplatelet effect. We want to restore TIMI flow, or to improve TIMI flow, because we know it has an impact on prognosis. We would like also to have an improvement in clinical outcomes. We want to have a fast offset of action when we stop the drug, because if there is a complication, we want to stop it and get rid of the effect. We don't want to see an excess of bleeding complications, and we don't want to see thrombocytopenias that we had with the previous GPIs. This is the ideal drug for primary PCI. Is this drug Zonfiban? This is a question for today. What do we know already from the phase 2 studies? We're going to talk about it. What do we expect from the phase 3 study, which is ongoing? Some of you may participate to this clinical trial. And finally, Zonfiban, which is a GPI, a glycoprotein 2B3 inhibitor, given subcutaneously, suggests that we may go back to the future with GPIs to pre-treat STEMI patients. We will discuss that today. So merci and welcome to the city. And make sure to come for the Olympics. It's also a good time to visit Paris. Thank you very much.
We will.
So we will continue, keep your questions, and we will take the questions at the end. We have 15 minutes for discussion. So let's move on with Joe Tenberg, and he will speak about Zonfiban that I just mentioned with a clinical case.
Well, thank you, Gilles, for a kind introduction. My task today is to talk about optimal antithrombotic therapy in several cases of patients with STEMI undergoing primary PCI. These are my potential conflicts of interest. I'd like to highlight that I was the PI of a phase 2 study with Zonfiban, and I'm also a member of the steering committee of the phase 3 Celebrate trial. Just as a background, in the Netherlands, patients with STEMI potentially going for primary PCI are treated in the ambulance with unfractionated heparin, aspirin, but also ticagrelor, orally, of course. Despite the fact that it's for ticagrelor only a 2B or 2B class, level of evidence B indication, according to the EC guidelines. And that's, of course, based on the Atlantic trial, which was a large outcome trial of over 1,800 patients. Patients were randomized to ticagrelor in the ambulance or placebo, and this trial was negative for two co-primary endpoints. So first, ST segment resolution, more than 70%, which was not different between the two groups, so placebo or ticagrelor, and also no difference in TIMI3 flow. So why was this trial negative? Well, we know that for P2Y12 inhibitors to become active, it takes at least 2 hours, and in most STEMI patients even longer, maybe 4 to 6 hours. And the second reason might be that P2Y12 inhibitors don't get a very strong inhibition of platelet aggregation. As you can see on this slide, from the Fabulous Faster trial, Prasugrel, it's the blue line and the green line, obtain platelet aggregation up to 40 to 50% inhibition. And even Cangrelor, which is an IV P2Y12 inhibitor, which acts immediately, has almost the same inhibition of platelet aggregation. So only the 2B3A inhibitors act more strongly than the other agents. So in this trial, platelet inhibition was over 90% with Aggrastat, Tyrofiban, and that is also maybe why the On-Time 2 trial was a positive trial. So the On-Time 2 trial was also a pre-hospital trial where STEMI patients potentially going for primary PCI were randomized to placebo or Tyrofiban. And as you can see on the right side of the slide, the primary endpoint, ST segment resolution, was better. So it was there was more ST segment deviation or resolution in the Tyrofiban group than in the placebo group. So despite the fact that we have a positive trial with 2B3A inhibitors, the guidelines state that you should not use pre-hospital 2B3A inhibitors. So why is that? I do not know the answer. Maybe Gilles or Arnaud is going to help later on why it's not advocated to use 2B3A inhibitors. But I think that it's quite cumbersome to use them because they are IV administered. You need a intravenous infusion controlled by a pump, and that's quite difficult to achieve in the ambulance. The second reason might be that they have a very long half-life, and of course that can cause bleeding, especially in those patients who need urgent CABG. And they can lead to thrombocytopenia. As Gilles just told us, we need a better 2B3A inhibitor. It should be as potent as the IV 2B3A antagonist. It should be as rapid, but it needs a shorter duration of action. Maybe a subcutaneous route, because that's easier, of course, than an IV bolus, and potentially does not lead to thrombocytopenia. And Zonfiban potentially has all these characteristics. I'll show you two cases of STEMI patients who underwent primary PCI who were included in this phase 2 trial. So the first one is an 85-year-old female, symptom onset 1 hour and 15 minutes before presentation. The second patient is a 57-year-old male, and the presentation was slightly later, so 1 hour and 30 minutes after symptom onset. In this phase 2 trial, there were no patients with shock, so they had normal blood pressure. And as said, they were used with or loaded with usual care, aspirin, ticagrelor, and unfractionated heparin. This is the ECG of patient A, extensive myocardial infarction, inferior wall and posterior wall, and the second one is a smaller inferior wall myocardial infarction. So these patients were admitted to the hospital, and in the cath lab were treated with Zonfiban, and that was roughly 15 minutes before the angio and the PCI were done. On the left-hand side was the first patient who got the lowest dose of Zonfiban, and the right side is a patient who got the highest dose. And you can appreciate the difference. The first patient has a blocked artery. The second one has an open artery. TME flow is not 3, but 2. And there is obviously a large thrombus burden. Interesting to see in these two patients is the platelet inhibition, which was lower in the first patient who was treated with a low dose of Zonfiban, and much higher in the high-dose patient B. This is the ECG post-PCI, which shows residual ST elevation in the first patient. And this is the ECG of the second patient, which showed no residual ST elevation, so resolution of the ST segment. This is a summary of the phase 2 trial. So again, those patients with STEMI were admitted to the hospital and treated with Zonfiban with 1 injection in the left upper arm at the table. In total, there were 3 groups of patients, each 8 patients, containing 8 patients, and they got dose adjusted, weight-adjusted doses. Lowest dose 0.075 and the highest dose 0.11. And the most interesting part, of course, is the pharmacodynamic results. It's the upper right panel here, showing that Zonfiban achieves very high platelet inhibition within a very short period of time. So within 15 minutes, you get 80 to 95% of platelet inhibition. And in also a very short period of time, roughly 2 hours, it wears off. We also looked at safety, and there were injection site bruises, there were mild exercise bleedings, but there were also 2 major exercise bleedings in the upper or in the lower arm, which were probably related to the drug, but also afflicted by a terumo wire which perforated the radial artery. We also did an exploratory angiographic analysis to assess the relationship between the dose and the amount of platelet inhibition and flow in the trial. And this is the results. So on the left-hand side is TME flow grade 2 or 3, and that was obtained in 1 patient out of 7 in the lowest dose. It was 6 out of 9 in the medium dose, and it was 7 out of 8 in the high dose. And quite similar was blush flow. So myocardial perfusion, grade 3, was present in 1 in the first group and in 7 out of 8 in the highest dose group. Thrombus grade was lower in those patients who got the higher dose of Zonfiban, as you can see here. Depicted in another way is the correlation between platelet inhibition and TIMI flow grade on the left-hand side, similar concentration of Zonfiban and TIMI flow on the right-hand side, which shows that if the platelet inhibition is higher, there was better flow, and if the concentration of Zonfiban was higher, there was better flow. Similar results were for blush, and related to thrombus grade, the patients with the higher inhibition had less thrombus burden than the patients with lower platelet inhibition. So in conclusion, pre-hospital oral P2Y12 inhibition does not work. It does not improve flow, it does not improve outcome. Pre-hospital IV 2B3A inhibition, as in the OnTime 2 trial, did improve reperfusion and outcome, but those agents have one problem. It has a very long half-life, which potentially leads to more bleeding, especially in those patients who have to undergo carriage. And subcutaneous Zonfiban administered in the cath lab, as we did in the phase 2 trial, very shortly before PCI, only 50 minutes between administration and performing PCI in this phase 2 trial, showed very promising results and is now tested in a large pre-hospital phase 3 randomized clinical outcome trial, which will be discussed by Arnoud.
Thank you very much, Ger. So we are back with GPIs. Arnaud, it's time to tell us more about the role of GPIs in primary PCI. Where do we stand with this? What are the perspectives on the use of GPI and possibly in the pre-hospital patients?
Yes, thank you very much, Gilles. Welcome, everybody, and I will speak about this unmet medical need in STEMI. And as Gilles and Jurtenberg already pointed out, this is an important aspect, because everybody knows that the STEMI is based on time. And when we treat these patients on time, we have better results. These are my disclosures, and I'm also a consultant for Cellacor Therapeutics. So we all know that the early restoration of blood flow in the infarct-related artery improves clinical outcome. And that oral agents, as you just pointed out, failed to improve the early patency of the IRA, as also was seen in the Atlantic trial that Gilles and I organized many years ago. So we also know that when we give these GPIs early enough, that they improve the early patency, but they also increase the bleeding risk. So we need there's a clinical need of more potent and predictable antiplatelet agents that restore patency in the pre-hospital setting without increasing the bleeding risk. And what we know that in daily practice, and this is a big study with many thousands of patients in the US, that many patients arrive too late after symptom onset. And patients who are treated too late, they do worse as compared to patients treated early. So the guideline tells you that you should treat your patient within 120 minutes. And when you treat later these patients, they have a more than 3 times higher risk of mortality. And when you, for example, perform your diagnosis within or over 90 minutes from hospital arrival to PCI, then you have a 3.7 times higher rate of mortality. And this is not uncommon, as you can see that the majority of patients, they arrive too late. So they are diagnosed too late, but also they are treated too late. So this is not old data. This is published in JAMA of 22. So nowadays it's still there that we treat the STEMI patients too late. And I think it's important not only to open up the epicardial vessel, but we know from our previous work that you really should bring the blood to the microcirculation. And we know this is not only data from Mike Gibson in the Boston lab, but it's also work from our lab in the Netherlands, and it's called the myocardial blush, in which you can have an idea whether the microcirculation is reperfused, yes or no. For example, if you've got myocardial blush grade 3, you see this extensive coloring of the microcirculation, whereas when you have myocardial blush grade 0, you have TIMI3 flow, but there's no microcirculatory reperfusion. And these patients do worse. And it also can be assessed using the ECG. If you've got complete ST segment resolution 1 hour after PCI, like this patient or this group of patients, you have a very good outcome. Whereas despite the fact that you've got TIMI3 flow of the infarculated vessel, but still ST elevation on your ECG 1 hour after PCI, you have a poor outcome. So your ECG tells you something about the extent of myocardial reperfusion, because we know that these are patients all having TIMI3 flow post-MI, but this is epicardial flow. You really need more information about the restoration of the myocardium. And this is what happens when a patient is pre-treated very early with sufficient antiplatelet therapy. You've got your diagnosis at 11 o'clock in the ambulance, showing that there's extensive ST elevation in the inferior wall and also lateral wall. And you give the aspirin, heparin, ticagrelor, and study medication in the OnTime 2 trial. And 40 minutes later, before you perform your PCI, the moment the ambulance arrives at the PCI center, you already have complete resolution of your ECG, and the patient is no longer having any chest pain. And this occurred in 19% of the patients pre-treated with Zonfiban, whereas it was present in 14.6% in the patients pre-treated with placebo. So 1 in 5 patients has already complete resolution of your ECG before doing your PCI. And you can imagine that this is associated with improved outcome. And this drug, Zonfiban, is a special drug which really is mimicking the Zonfiban molecule, but it has a distinct capacity that is giving you the specific capacity of your ideal antiplatelet drug. And as was already pointed out by Jur in the CELO-2 trial, that it has a rapid onset of action within 15 minutes with a subcutaneous administration. So it's not IV, it's subcutaneous, like your vaccine. You give it in the upper part of your arm, and it works within 15 minutes, and you have a quick offset within 4 hours. So it's not a drug which holds long after the single administration. And this is what we aim for in the CELEBRATE study, because patients are pre-treated with aspirin, heparin, and ticagrelor in the majority of patients. And we know that ticagrelor takes at least a few hours to become active. And with the RUC4 or Zonfiban, you aim to have your potent antiplatelet effect the moment you perform your PCI, so within 2 hours after drug administration. Whereas when you just give ticagrelor, you perform your PCI with still active platelets. What we know about Zonfiban, when you compare it to another subcutaneous antiplatelet agent like selatogrel, we know that Zonfiban works differently. Because the Zonfiban, the block-specific activators, the platelet aggregation induced by Zonfiban also blocks thrombin. And we also know that thrombin is one of the most potent agonists of thrombosis. And here you see in the study of of Curry and Sam Ricken that when you compare the effect of Zonfiban to selatogrel and you look at the ADP as an agonist for platelet activation, that Zonfiban and selatogrel have the same antiplatelet effect. But when you look at the trap-induced platelet inhibition, you see that Zonfiban has a very potent effect on platelet inhibition, whereas selatogrel has almost no effect on trap-mediated thrombosis. So this is really the reason why the P2Y12 blockers do not induce reperfusion, like we saw in the Atlantic study, like ticagrelor, and also selatogrel is probably not giving the reperfusion, whereas a drug like Zonfiban, which really blocks the thrombin-induced platelet aggregation, will cause reperfusion, as was seen in previous GPI trials. So, and this is what already was mentioned, that we look for the ideal antiplatelet drug, and we look for drugs which has a rapid onset of action, which is easy to administer, which inhibits all platelet aggregation pathways, which can open a closed coronary artery, has a predictable response, has an absorption which is independent of opioid administration, which is also important when you give the morphine in the patient, which has a low likelihood of thrombocytopenia. And that's why we are looking for the clinical efficacy of the drug in the large phase 3 randomized trial, which is called the CELEBRATE trial. And recently the design of this trial was published in the American Heart Journal. And here you see that the STEMI patient who is got less than 4 hours of chest pain, who give verbal consent in the ambulance, is randomized to either Zonfiban at a dose of 0.11 micrograms of milligrams per kilogram, or a higher dose of 0.13 milligrams per kilogram, or placebo in slightly over or slightly under 2,500 patients, and then the patient is transported to the PCI center, and we look at the primary efficacy and safety endpoints. And these are the this is the design. It's a randomized, double-blind, placebo-controlled, international, multi-center pivotal trial of a single subcutaneous dose of Zonfiban in subjects with ST elevation, myocardial infarction, presenting in the pre-hospital setting. So it's really a setting in which patients are diagnosed early after the onset of symptoms. We look for STEMI patients in which the total duration of symptoms is less than 4 hours, because then we know that platelets, or that the thrombus is still very platelet rich, as was shown by previous work from Professor Montalesco, that in this situation you have the highest potency of inducing reperfusion. And this study is now currently enrolling in the Netherlands, in the Czech Republic, in Hungary, in France, in Canada, United States, and I'm very also proud that the PI of Mexico, Dr. Arias, is present at this meeting. And also Romania is the country which is currently enrolling patients at the ER who have to wait more than 30 minutes before they can go to the cath lab. So we expect the results of this trial at the end of this year, and we hope to show the results next year in the first quarter. And we look at the primary endpoint, which is the 30-day win ratio based upon the composite of death, stroke, recurrent MI, acute stent thrombosis, the new onset of heart failure or rehospitalization for heart failure, a peak high sensitive troponin of higher than the 10 times the upper limit of normal, or none of the above. And we also look, of course, at safety, which is defined by the GUSTO definition. And of course, with this steering committee, with including Mike Gibson from from Boston, from Harvard Medical School. We look at pre-PCI TIMI frame count, we look at post-PCI ST resolution, and of course at overall safety. And this is a slide which you show in a mouse model what happens if you have the endothelium damaged using radiation, and you see what happens in this damaged endothelium when you do not have antiplatelet drugs in place. And in the left you see the situation without the drug, and on the right you see the situation when you have Zonfiban on board. And you see that when you do not have antiplatelet agent, there's occurring a clot very rapidly, and when you have RUC4 or Zonfiban present, you see that there's still some sort of thrombosis occurring, but it is prevented from becoming an occluded clot. So in conclusion, that pre-hospital treatment delays and mortality remains unchanged for 40 years. This is really a matter of concern. We know that time is muscle, and that GPIs can facilitate primary PCI, that Zonfiban is a new, rapid-acting, short-lived GPI that provides a new, immediate pre-hospital treatment, and that data from the phase 1 or 2 trials in healthy volunteers show that Zonfiban is a prompt, potent, predictable, and persistent drug, which is easy to combine with P2Y12 blockers, and also because of the short half-life, is easy for the surgeon to operate these patients, because within 90 minutes platelets are functioning normal again. So we expect this pivotal trial, and we look forward to the results. Thank you for your attention.
Thank you very much, Arno. If you have questions, we have microphones in the room, of course. Maybe while waiting for the first questions, I can ask you, we have a kind of disconnect between what the guidelines say nowadays, which they are very conservative, no GPIs, almost, and certainly not as a pretreatment in the ambulance. And what we see with 2 major phase 3 trials with new GPIs, and this time being used in the pre-hospital setting. While waiting for the results, what do you do in your patients between these very conservative guidelines and what you expect from these randomized studies?
Yeah, it's a good question, Gilles. I know that when patients come in who received ticagrelor only 1 hour ago, so you know that the patient is not having antiplatelet therapy at all, and you see a large thrombus burden in this specific patient, I really give kind of routine the tirofiban in this situation, because already we know that the risk of stent thrombosis is too high when you have not sufficient platelet inhibition in these patients. So I think we should really go back, as you pointed out, Gilles, to this pre-treatment and also this more aggressive antiplatelet treatment in STEMI. A bit against the guidelines, but I'm sure that these guidelines should be changed in the coming years.
At least it's good for the trial to have these guidelines. Joe, there is a question here. In a patient presenting in a center without PCI facilities, and let's say 90 minutes away from the cath labs, this gentleman asked, I usually give TNK. Can I expect to replace TNK by Zonfiban?
Well, I don't know whether it should be Zonfiban. I mean, at this point of time doing a study, but replacing it by an IV 2B3A inhibitor might be a very good idea. I mean, it has been shown in the On-Time 2 trial that especially the patients who present early but have a long driving time favor the most from ticagrelor, Aggrastat, in the ambulance. So I would say yes, it might be even better and safer to use a 2B3A inhibitor than lysis, because we know that lysis leads to roughly 1% of intracranial hemorrhage.
But again, we have an issue with the guidelines, class 3 accommodation.
Yeah, but you should not always listen to the guidelines.
Don't read the guidelines. Okay, I have another question. Can we expect these drugs, Zonfiban, being used in what you just described? Patient with a big thrombus burden in the coronary. This is a GPI with probably a better safety profile than the previous GPIs we knew. Can we imagine to treat this thrombus burden with Zonfiban? Do we need data to do that? A new study?
Yeah, I think we need data, but it's not an experimental drug. It's a drug, as I showed you. It's mimicking highly tirofiban. It's a subcutaneous drug. It's a short half-life. So if you think that these drugs can really induce dethrombosis, I would not be very hesitant to treat these patients with a high thrombus burden, which you know that there's a high chance of no reflow with Zonfiban. Yeah.
Yes, you remember we started doing this with IV GPIs. We continued with intracoronary GPIs. So maybe one day it will be intracoronary Zonfiban. Question here.
Thank you. I just asked a question. Maybe I do know this is interesting to know the results if we do another arm with using this drug or an IV just in the coronary cath lab. And this is the problem, because if you have a drug is acting rapidly, we cannot have a difference between using before and inside the cath lab.
It's a good point. We had this discussion, and clearly not all patients, even the study, if the study is positive, I'm sure that we won't see all the patients presenting early with an acute MI being treated with Zonfiban before being transferred to the hospital. So they will come to the cath lab naive of GPIs, and the next question will be, can I use Zonfiban sub-Q, IV, intracoronary, because I have a big thrombus burden, and help this gentleman with an acute MI, or this lady less frequently with an acute MI by doing this. We don't have data to answer the question.
Yeah, but I definitely agree. I think by pre-treating the patient, you really have the extra effect on dethrombosis during transportation. So that's something which can help even more. But if you have a patient who is not pre-treated, I really would say don't bother and give a more effective antiplatelet agent. Yeah.
And especially in countries where driving times are relatively short. For instance, in the Netherlands, the mean driving time is 30 minutes. So there's not too much difference between pre-treatment and in-hospital treatment. So another good case to start the drug when you see the angio and see that this patient has a very large thrombus load in the cath lab.
Joe, there were two major issues with GPIs in the past. The first one was bleeding, major bleeding. I think it decreased a lot with the use of radial access, but still it's in the mind of people. And the second one was thrombocytopenias. Do you want to tell us what you think about these two complications of the past and what we expect to see with Zonfiban?
Yeah, I think the area now is totally different because, as you say, we need we take the radial approach in more than 95% of the cases, and I always had the feeling that patients bleed not only because you actively inhibit platelet activation, but also because there's a mechanical problem. And that was the case very often with the femoral approach, which is not the case. We had two, to be honest, in the CELO-2, so the phase 2 trial, but both were mechanical problems where the terumal wire perforated the radial artery and the patient bled. So I think with the radial, the problem of bleeding is very much decreased as compared to a previous area when we used the femoral. And the other question about thrombocytopenia, theoretically, there is no thrombocytopenia with this new drug. It doesn't give the conformational change of the receptor. And we have not seen thrombocytopenia in this small phase 2 trial. It was only 27 patients, so it's too early to say that there is no thrombocytopenia, but it is very promising.
Very good. Just to answer the last question I got here, no, there is no experience with CPR patients with this drug. But of course, we know that they are intubated, they get resuscitation. We cannot give them effective P2Y12 inhibition, so clearly it would be very tempting to have this kind of drug. I think we come to an end of this session. Thank you very much for being with us. As you see, we need to wait a little bit to get the results, but we are hopeful to get positive results for this drug in the context of STEMI patients with clearly no excess bleeding complications, without thrombocytopenias, but with better reperfusion, better clinical outcomes. We'll see. We need to wait. We need to randomize a few more patients, what we do in our daily practice here, and we will tell you if we are back to the future of GPIs. Thank you very much for coming.